fetus. So, phase of a decreased sensitivity to insulin, the fasting glucose levels are high, are low, because most of the glucose in internal circulation pass the placenta and go to the fetus. The gluconeogenesis is decreased, and insulin-dependent glucose availability is decreased too. In in the second half of pregnancy, the protein turnover and lysis is increased. So all of these changes are aimed to the need of the fetus. But usually, said it, I think before when we talk about internal modification during pregnancy, internal pancreas reacts in the insulin production. If it doesn't happen, something goes wrong. So we have four types of diabetes in pregnancy. Of course, type 1 diabetes is rare, insulin-dependent diabetes. Type 2 diabetes, early diabetes, which is very rare, is the mature onset diabetes of the young. Something like a late type 1 diabetes, which need insulin to be treated. Or most common type of diabetes in pregnancy is the gestational diabetes, which accounts 5%. Well, there are effects of diabetes on pregnancy, and there are effects of pregnancy on diabetes. Diabetes increases the risk of miscarriage, congenital malformation. These are particularly related to glycated hemoglobin and hypoglycemic crisis. Increases the risk of preeclampsia, preterm birth, preterm rupture of the membranes, usually due during diabetes to urogenital infection, increased quantity of amniotic fluid, which is called polyhydramnios. Diabetes and pregnancy increase the risk of fetal growth restriction. On the other hand, fetal macrosomia, dystocia, which means problems during labor and delivery, often requiring instrumental deliveries such as cesarean sections or instrumental delivery with forceps or vacuum extractor and so on. But there are effects of pregnancy on diabetes. Pregnancy may increase the risk of development of worsening of diabetic nephropathy and cardiovascular diseases, existing the risk of worsening of retinopathy, nephropathy, and increase the risk of hypoglycemic crisis, particularly under insulin treatment and mainly nocturnal. So during pregnancy, insulin treatment should be adjusted for pregnancy. You can tell me why the hypoglycemic crises are increased during pregnancy. The risk of hypoglycemic crisis. Yes, because the fetus receives glucose, so the need for insulin is usually lower than for pregnancy. And of course, pregnancy increases the risk of infections. which is the management. First of all, for pre-existing diabetes, preconception counseling is fundamental. And we have to do a pre-pregnancy evaluation, check for the duration and severity of the diabetes, presence of acute and chronic complications, to know what the treatment is, and to check for comorbidities. Treatment is important to be known because during pregnancy we can use insulin. We can't use hypoglycemic agents, oral hypoglycemic agents. Then the most important thing is to evaluate a metabolic control. Glycated hemoglobin should be less than 1% of the normal range, and there must be not hypoglycemic crisis during organogenesis period, because the hypoglycemia during the organogenesis is an important risk factor for fetal malformation, such as an increase or elevated levels of glycated hemoglobin. Pregnancy may be allowed if glycated hemoglobin is less than 7%, the preprandial blood glucose is between 90 and 130, postprandial blood glucose less than 100, normal blood pressure, and normal lipid profile. So these cases, pregnancy may be allowed, otherwise it may be delayed until an optimal metabolic control is obtained. This is particularly true only true for type 1 and type 2 diabetes, so for diabetes pre-existing pregnancy. Remember that anyway, we call gestational diabetes any degree glucose intolerance with onset or first recognition during pregnancy. Maybe also type 2 diabetes, usually not a type 1 diabetes, which is known usually during teenage period. But anyway, we call gestational diabetes a diabetes diagnosed during pregnancy for the first time or recognized for the first time during pregnancy. Pathophysiology of gestational diabetes is, we have known there is a peripheral insulin resistance which has to be balanced by an increased insulin secretion by the cells of the pancreas. Doesn't happen. Is an insufficient insulin secretion by the pancreas. Is a lack of adaptation of pancreatic function throughout pregnancy. This may lead to gestational diabetes. During gestational diabetes, unless it is not an unrecognized second type diabetes, if it's a true gestational diabetes, due to this mechanism, not pre-existing pregnancy, usually the fasting glucose blood levels low. If you only do a test morning, check for the fasting glucose levels, almost always you can't diagnose diabetes because they are low, even in case of gestational diabetes. Which are the risk factors for gestational diabetes? We distinguish among major, minor risks anamnestic risk factors and risk factors related to ongoing pregnancy. Major anamnestic risk factors are previous gestational diabetes in a previous pregnancy, or having a first degree relative, one or more first degree relative diabetes, age over 40 years, or BMI over 30. Fetal macrosomia in previous pregnancy. Macrosomia means newborn birth weight greater than 4 kilograms, or anyway large for gestational age. This means large for gestational age, exceeding the 19th centile growth. Or major anamnestic risk factor is also a previous unexplained perinatal death. So uterine. Minor anamnestic risk factors are previous recurrent miscarriages, preterm birth, polyhydramnios, excess of amniotic fluid in previous pregnancy, or hypertension or preeclampsia in previous pregnancies, pluri or multiparity, or a BMI between 24 and 29. So an overweight, not overweight patient may be at risk of gestational diabetes. There are factors related to the ongoing pregnancy, excessive weight gain, for example, more than 1.2 kilograms in the first trimester, or more than 400 grams per week, second trimester. A recurrent fasting laxuria is quite common in pregnancy because there is a reduction of glucose reabsorption by the kidney. But the recurrent fasting glycosuria is not common and is being investigated for gestational diabetes. And also an excessive fetal growth or polyhydramnios in the ongoing pregnancy are risk factors for diabetes. The gestational diabetes is not so dangerous for the mother, although it's a risk for development of second type diabetes later in life, but it's dangerous for the fetus. One of the major problems is that the excessive amounts of glucose passing the placenta and going through the fetus stimulates in the fetus insulin and insulin-like growth factor secretion, which are responsible for excessive fetal somatic growth. So fetus become a macrosomic fetus because of gestational diabetes if the metabolic control is not correct. Okay? This is one of the most important things. Not only this, but one of the most important complications. Well, the diagnosis is done if fasting blood glucose is greater than 92 milligrams DL first trimester. Remember that in this case, it is reasonable to think about not previously diagnosed second type diabetes. If the fasting blood glucose is high first trimester, probably and with a pre-existing diabetes not diagnosed before. Otherwise, the most common way to diagnose gestational diabetes, the most common test, is the oral glucose tolerance test, which is done at 24, 28 weeks of gestation in presence of minor risk factors, or before at 16, 20 weeks in presence of major risk factors. The load goes solution with 75 grams glucose is administered to the patient. And the basal or fasting blood glucose at 60 minutes after take of the solution, so 2 hours later, are measured. These are the threshold. Diagnosis is done if at least one of these 3 values are over the threshold. That's 2 milligrams basal, 180 after 1 hour, 153 2 hours. After having diagnosed diabetes, gestational diabetes, we have to try to reach an optimal glycemic control. This is the target of the management. And the target are fasting glucose less than 90 milligrams, less than 140, 60 minutes after meals, less than 120, 2 hours after meals. External blood levels greater than 60 milligrams. Because remember that hypoglycemic crises are more common during night. You can check the control, verify the control of a capillary profile. Treatment consisting first approach is a diet. Diet means complex carbohydrates, proteins, and unsaturated fats in those percentage. If the diet it's not enough, if it doesn't work, we have to use insulin to control glycemia. Usually we use administration of insulin, fast insulin before meals, and slow administration of slow insulin, 23 Hypoglycemic agents are not used in pregnancy, are contraindicated, maybe except metformin, which now is used in those cases with metabolic disorders. Using metformin before pregnancy, they can keep on taking metformin during pregnancy. I think it's safe, but it's not still recognized as an official treatment of gestational diabetes. Of course, we have to suggest physical activity, one of the most difficult target to reach is that a pregnant woman, usually pregnant women, don't do physical activity at all. It's very difficult for them to do that. Anyway, we have to suggest that physical activity may be useful not only in the treatment of gestational diabetes, but also in the prevention of pregnancy complications such as preterm delivery or preeclampsia. But it's a very difficult which are the fetal and neonatal risks of diabetes in pregnancy. I said before, for gestational diabetes, problems for the mothers are not so great. Main problems are for the fetus and the new. But any type of diabetes has its own complication during pregnancy and its own risks. There is an increased risk for congenital malformations, particularly in type 1 diabetes. These malformations are neural tube defects, heart defects, renal and neural defects. These are the most common malformation due to type 1 diabetes. And remember, these factors of fetal malformation are high levels of glycated hemoglobin, high frequency of hypoglycemic crisis at the beginning, during organogenesis. All the three types of diabetes, type 1 and 2, and gestational diabetes, may be responsible for fetal macrosomia. Same mechanism, great amount of sugar, of glucose, passing the placenta, reaching the fetus, and inducing inside the fetus the secretion of insulin and insulin-like growth factors, which are growth factor for, so the fetus grows too much. Type 1, 2, and gestational diabetes increase the risk of stillbirth. Stillbirth, it is the birth of dead baby. Recognize the death of the baby after delivery. Perinatal mortality. Perinatal mortality is intrauterine mortality after the fetus reaches viability week, after 23 weeks, remember, and in the first week after birth, first neonatal week. This is perinatal mortality. Type 1 diabetes may increase the risk of fetal growth restriction, particularly if associated with hypertension or damage to peripheral vascular function. Type 1, 2, and gestational diabetes increase the risk of respiratory distress syndrome, the newborn, because they may affect the surfactant production in the fetal lungs. So even a term baby may be at risk of respiratory RDS, distress syndrome, which is typical of the preterm born, because diabetes may affect the surfactant production. Usually the newborns, baby born from diabetic mothers, may have hypoglycemia, polycythemia, hyperbilirubinemia, hypocalcemia. These are metabolic disorders. These are metabolic disorders which are very common in baby born diabetic mothers. So the need of a correct metabolic control, semi-control is very important in this case, because gestational diabetes in particular is not so difficult to be treated. If it's not treated, it may be responsible for fetal and which may be very severe. We have a dedicated outpatient clinic in Santana Hospital for diabetes in pregnancy. It's the cooperation diabetologist, of course. I think that we can speak about begin to do this topic, which relates to hypertension in pregnancy. These are the guidelines which usually these are the societies which usually base guidelines on hypertension in pregnancy. This one is the Italian one. This is the symbol. American Society, College of Obstetricians and Gynecologists. These are the Royal College of Obstetricians and Gynecology, Canadian. And this one is the most important guidelines though, because it's an international, it's not a national guideline. It's an international guidelines, international society, which is called the International Society for the Study of Hypertension in Pregnancy. And we'll discuss hypertension in pregnancy mainly according to these guidelines, and particularly according to the suggestion International Society for the Study of Hypertension in Pregnancy. I still have some slides in Italian. Well, first of all, how to diagnose hypertension in pregnancy? Well, we find hypertension in pregnancy as a systolic blood pressure greater or equal to 140 and or a diastolic blood pressure greater to 90 milligrams. This is usual cutoff for diagnosing hypertension even outside pregnancy. Well, but during pregnancy, blood pressure elevation should be confirmed by repeating measurements according to the registered values. Well, if you measure a very severe blood pressure elevation greater than 160 or 110, you can confirm hypertension repeating the measurement after 15-20 minutes. One measurement is not enough. For less severe blood pressure elevation, repeated readings should be taken over a few hours, 4 or 6 hours. But remember, one measurement is not sufficient to diagnose hypertension, particularly in pregnancy. One important thing is to use a correct sphygmomanometer. Have to be validated to be used. Possible a liquid crystal sphygmomanometer. Anyway, they must be validated. Now that there are some devices measuring pressure anyways, fingers, so they're not real, particularly in pregnancy. It seems easy, but it's not. Well, one other problem we have is definition of proteinuria. Because proteinuria was a diagnostic criteria for preeclampsia, which is the most severe form of hypertension in pregnancy. So we have to define it. When the proteinuria must be considered significant in pregnancy. Till a few years ago, 3 or 4 years ago, say that significant proteinuria was when proteinuria was equal or greater than 300 milligrams 24 hours duration. But that means that you need to wait 24 hours to make a diagnosis. Now the things are a little bit changed and simple because proteinuria should be assessed initially by automated dipstick analysis when possible. Automatic system is not have to you need to have a device to check dipstick. Visual dipstick possible, but they are less reliable. Anyway, if the examination of the dipstick is positive, well, we have to do another exam to confirm proteinuria, which is the spot urine protein creatinine ratio. And the ratio is normal if less than 30 milligrams micromole or 3 milligrams, 0.3 milligrams per milligram. This is the cutoff values of this protein creatinine ratio. If the dipstick is negative, well, it remains negative. We don't need to do further examination. But one thing that we'll discuss, which is very important, proteinuria is not required any longer diagnosis of preeclampsia. If it is present as a diagnostic criteria, but we may have preeclampsia in presence of hypertension, also without proteinuria, if other organ damage signs are present. We'll discuss it because it's very important. Anyway, massive proteinuria, Rosie's range, is associated with more severe neonatal outcome. So we must know how much is the proteinuria. Well, this is the classification, and then we'll stop that. Classification of the hypersensitive disorders of pregnancy. We have two types of hypertension during pregnancy. First type is hypertension known before pregnancy, pre-existing hypertension, or hypertension which is diagnosed first 20 weeks of pregnancy, in the first half of pregnancy. First time. Type of this hypertension, pre-existing, not pregnancy-induced hypertension, but pre-existing. Chronic hypertension, that may be essential or secondary. White coat hypertension and masked hypertension. Then there is a second type of hypertension, which is more important for us, which is pregnancy-induced hypertension. So that means hypertension arising de novo at or after 20 weeks in previously normotensive pregnant women. And not only. Three types of this hypertension related to pregnancy are transient gestational hypertension, gestational hypertension, which persists, and preeclampsia. Preeclampsia is the most important type of hypertension, the more severe pregnancy. It's usually a de novo hypertensive disorder, but it may also be superimposed to chronic hypertension. So a woman with chronic hypertension at a certain time of pregnancy may develop preeclampsia. Well, let's define chronic hypertension. Chronic hypertension refers to high blood pressure predating pregnancy, recognized before 20 weeks of gestation. Usually, it is often diagnosed at the first visit, at the booking visit, or at least at the preconception counseling. Remember that often the first visit in pregnancy is maybe the first visit at all for a woman. So it's the first time, it may be the first time she has her blood pressure checked. So it is often diagnosed at the very beginning of pregnancy or before pregnancy during preconception counseling. Well, we have to be careful because office hypertension may be different from home hypertension. The blood pressure levels may be different when measured in hospital, in the office, by a doctor anyway, than they are when measured at home by the woman herself. So, ideally, a chronic hypertension should be confirmed with a repeated measurement at home, not necessarily with an automated blood pressure monitor, a Holter monitor, but at least by a measurement that the woman can do by herself if correctly trained to do that. So it's important not to base the diagnosis only on one measurement in the office, because it may be. Most cases of chronic hypertension in pregnancy are due to essential hypertension. Secondary causes of hypertension are common, but they are possible, particularly in young women, which may be high risk for some types of pathologies such renal pathology, autoimmune pathology, or endocrine disorders. Well, the cutoff of 140 and 90 millimeter is the cutoff we use for office or hospital measurement. But when measured at home, even values of 135 and 85 may be considered suspected for hypertension. Is it clear? So the values, the cutoff values, and the blood pressure is measured at home by the cell are lower than cutoff values we use in the hospital setting. And even if this pressure, these blood pressure values remain, these cutoff levels, 135, 85 at home, well, this may not be necessarily an entirely benign condition, because they may be, patient with these blood pressure values may develop hypertension or preeclampsia during pregnancy, during the course of pregnancy. 2 words on white coat hypertension. White coat hypertension is an hypertension which is measured only when blood pressure values are measured by a professional. And the woman refers that at home, her blood pressure is completely normal. To diagnose white coat hypertension, ideally we had to suggest home measurements, a repeated home measurement, diary of course, and if possible, they may be confirmed, the white coat hypertension may be confirmed by an automated blood pressure monitor measurement, 24 hours. Anyway, in case of white coat hypertension, we cannot avoid treatment, usually. We can wait for delivery until term, but we have to set a customized protocol of care for that woman because a white coat hypertension may be a risk factor for the development of persisting and chronic hypertension of preeclampsia later. So I think that we can stop here. And next steps are on mast hypertension. Well, next week, on Monday, I won't be here because I'm to work in the hospital. There will be my colleague. Will, in another topic, I will attention in pregnancy on next time. See. I will try to charge my slides on the